Of note, please note up on the board, I'm not gonna be here on Friday. You don't have to be here on Friday. Many of you are, I'm sure, leaving early, hopefully getting on your merry way. So if that's the case, I'll just record something and send you, because I don't know when I'm gonna be available then at all. That's the first significant, the more significant announcement is coming. It has to do with the exams, and I'm going to tell you in advance, it's a two-edged sword, but you'll probably appreciate one edge of the sword. I would say, in general, over all my sections, I still have another section to give it to, but it's the one that has the least students. I would say about 2/3 of the students improved, and about 1/3 didn't. And I saw a lot of you need to get certain grade targets, whether you're in health sciences or pre-nursing or nursing per se. So I understand that. And so, and again, I thought about it a lot. I'll tweak the exam to try to give it a certain degree of less complexity. And I'm going to look at, so I'm going to be consciously, particularly the stuff we're going to be doing today, and I'm going to send you on Friday. But because of that, I decided to make it an open book exam for the final. No, I mean, there's some people who are not taking the final because they've done, as far as they're concerned, well enough, whatever that is. They've achieved whatever grade level they want to achieve. And so if you have 3 grades you're satisfied with, send me an email, and I'm more than happy to tell you what your final grade would be if you decide not to take the exam. And if that's what you require, fine and dandy. Again, you can't get any less than that, because you could always, if you had a bad one, you could always throw it out. What is meant by open book? Here's the two edges. Open book is open anything. You can sit there with your laptop. You can sit there with your phone and Google or chat GTP, as long as it's working, which it wasn't yesterday morning because there was absent some sort of mega server. That I have no control over those things, obviously. If you want to do that, it's fine. The two edge, one is a time limit, 2 hours. Whatever our start time is, we're going to start at the same time. 2 hours, boom, handed, pencils down, done. And that, understand, the pitfall is the following. People don't prepare. Oh, he said it's open book. F that. I don't have to study. And there's a lot of people like that. It's an error. Because the complexity of the questions, as you already are familiar with, you really have to you have to have an idea what it's about, which means it requires some study. At the very least, it requires organizing materials, working with a study guide, etc. All the stuff many of you do anyway. Be careful. Because it kind of gives me license to pretty much ask whatever kind of depth of question I want. And I'm going to consciously try to take out some of the stuff that I feel might be more confusing than less confusing. So I'm doing that particularly, I do it for everybody. It's not no special gift to anybody, but I'm trying to let you achieve what you have to achieve, understanding the difficulties of the semester. I mean, if you move forward to AP2, I'm not teaching you. I mean, and by the way, if you're in micro, it's harder. Much. So I had a student in, it's a whole different ballgame. We're talking about structures that their anatomy and physiology you have to relearn, and it's totally different. Basically about bacteria and viruses, and they ain't like us at all.
Do you know how many questions the final's going to be yet?
Probably about 65 or 70, I would think.
Okay.
I mean, there's essentially 3 units worth of chapters. It's not cumulative or anything. It's really isn't. Everybody good? That's where we start. So, I mean, most people are like, oh my goodness, that's great. But I really am very sincere, have a lot of experience with it. I'm trying to be helpful and trying to be fair. I may not be great at what I do, but I would try always to be fair. Not one of you, again, could have said something like, oh, you've really done a great job. But no fishing for compliments with this group. It's all right, nobody else said it. I digress. Moving on, we have, in no specific order, we have several topics from each of these PowerPoints. These are the ones that are labeled as Chapter 12 PowerPoints that are there. So they're all relevant. We will only really we'll do some, wrong one, blue. We'll only get a limited amount there because there's 4, and that's why I went to that one. And that's A, and hopefully it should be B as well. And I don't want to rebuild the wheel or anything with regard to that. But if we're doing 12 on the A, basically I wanted to talk about what these things called ventricles to start. Effectively, again, it's a hollow tube filled with fluid. The fluid is cerebrospinal fluid. We'll come to understand later as we look at cerebrospinal fluid, when we look at the layers of the brain, the outer layers that are the surrounding structures that support it, called the meninges or meninges, more about the cerebrospinal fluid. The cerebrospinal fluid is contained in what are called ventricles within. Again, it's a hollow tube that's formed from the rim of the tube has thickened and enlarged. That's effectively what we call our brain. The fluid inside stays there, although it's changed its shape in a variety of ways and looks kind of like this from the front, from the sides. Those are these chambers. They're not hollow. The fluid is in there, so it allows our brain to float. And effectively, the fluid has means of egress, which means it's got escape hatches. Here, 3 of them. Here, and 1 in the back. Anybody, if there's, please, no more talking. And the 4th ventricle, and there's also, you will see the fluid actually is able to attach all the way down the central canal and at the very bottom of the spinal cord, which I'll point out again in the recorded lecture for Friday, is how it escapes. And it surrounds the brain. And you'll come to learn in something called the subarachnoid space. The 3 layers you're going to learn are the dura, the arachnoid, and the pia of the meningeal layers, which is an important anatomical part as well. That's what these are about. Hollow chambers filled with fluid, with cerebrospinal fluid, similar but certainly distinct from plasma. And so effectively they derive their names. The neuroglial cells or the ependymal cells, they keep it flowing. They help to finalize it. Okay. And these ventricles, they used to be called first and second. Now that since they're identical on either side, we call them lateral ventricles. They have a membrane between them, which sometimes is not always there. It's really not a giant pathology. It can cause some behavioral problems in children, and it's called the septum pellucidum. I'm making sure that's not going to be on there. But I want to mention it for the sake of completeness. And then you're going to see there's passageways, effectively this tube, enlarged, widened, spread out, narrowed, enlarged, etc., around the major areas. The lateral ventricles are around the cerebral cortex. There are 2 of them, 1 on either side. The 4th ventricle, I beg your pardon, the 3rd ventricle is around the diencephalon, which we'll cover today, the thalamus, the hypothalamus, and the pineal gland. And then between, and very importantly, as you will see, between the brainstem, midbrain pons and medulla, and the very large cerebellum, is the 4th ventricle. That's where the points of egress, these little openings called apertures, are located. 2 on either side, hence the term lateral, and median midline in the roof. And I showed that to you before, and I'll show it to you again. Here's what it looks like from the side. Kind of a C, but it's got a tail. So frontal lobe, parietal lobe, occipital lobe, temporal lobe. Same thing here. You can't see. And if you've wondered, this is when we look at brain scans and we look at MRIs and CTs of the brain, these hollow chambers give us an idea of the location. That's how radiologists are able to use these interesting tools of advanced imaging to be able to determine, say, where a tumor is or where there's been damage. So that, and we have a lot of students and in health science, and I'm sure it's still there, where they are involved in pointing toward a career in nuclear medicine. It's very, very interesting. And so they become, and so really the anatomy is really a significant part in interpretation of these things that are there. So here are the lateral ventricles. There's a place between, there's a flow point, as you can see, called the interventricular foramen. Then the 3rd ventricle around the diencephalon. And then here, 4th ventricle, relatively flattened out here. That's the median or rooftop aperture. And then the lateral apertures on either side between the cerebellum, and this is the brainstem. That's where it's located. The money area of the brain, the cerebral hemispheres. that are there. This is really what you probably learned a fair amount in anatomy. I'm not going to revisit that. Gyri and sulci and fissures will show you this. But again, you need to have an idea of the general activity of each one of these lobes. Frontal, you're going to see main processing, language, communication, reasoning, you know, anything that you can, commanding any type of motor orders, how we affect our surroundings and affect each other and even affect ourselves. The parietal lobe, purely sensory from the body, very specific. We call it generalized sensation. You know, is it hot? Is it cold? Is it sharp? Is it dull? That's about what it does. And then we take that information and we work with it to determine what that means and how we should react. And you'll see the construct of that. Occipital, tremendous amount, half of all of our circuitry, visual processing. This is the processing center. This is where it receives the visual impulse. It filters it, refines it. And as you will see, just like with general sensation, or just like with auditory sensation here in the temporal lobe, basically it processes that information, sort of gets it ready, encrypts it in any way, shape, or form, and shuttles it forward to the frontal lobe and say, here, you just saw that. What does that mean? You were driving. You just saw a ball go across the street. I know what my dad told me. Maybe your dad or your mom told you that. If you see a ball, stop your car. Because there's going to be a kid running after that ball. If you didn't hear that, do that. So that's what you mean by processing information. And we process it very, very quickly so you can react very, very quickly. So again, those are the names of the lobes. The insula is primitive. It's for smell and taste. They're very, when I say primitive sensations, that's why we see them. It's, again, particularly smell evokes emotions. It's tied to the limbic system, which is our emotional center, which you're not going to see the construct of until I send it to you on Friday, but I'll talk about it today. Straightforward, interesting. On the sheep brain, you never see the central sulcus. It's not well defined. It's a little easier to see in the human brain, which we do not have access to. Though you have the sulcus, the gyrus immediately in front of it, precentral and the postcentral gyrus are, this is, we call it the primary motor gyrus. This is where command went out to my hand to grab that. Okay? Sensation. When I touched that table, okay, and I felt what it was like, the edge of the table, that came through the precentral, I beg your pardon, the postcentral gyrus. Primary motor, and this would be primary sensory. To determine to do that, I had to do some thinking, and having struck that, I have to do some thinking as to say, what does it feel like? Is there something irregular? I get some dirt on here. Do I have to wipe it off, etc.? All those kinds of things are from that. Those are really important areas in the brain, as you will see. That's really where we were directed, and we even have it mapped out as to how much we devote of our motor or our sensation to certain areas. It may surprise you, maybe it won't. And then there's that insula, that primitive area, and they talk about all these different ones. Again, where we see cortex is only on the exterior of the cerebral lobes, those I just told you about, frontal, parietal, occipital, temporal, etc., and on the cerebellum. Those are the highest order processing areas. Most of the circuitry is there: synapses, cell bodies, dendrites, supportive tissue, not axons, not white matter. Okay, the white matter, there's a lot of. Those are the passageways, whether it's sending it across, whether it's sending it forward and back or up and down. And then, as you can see in the cerebral area, we have the basal nuclei. They're the ones that we implicate in motor disorders in the sense of like Parkinson's, or as you will see, Huntington's disease. Effectively, that's the fine tuning. I mean, it's not me. I can just grab this and do that. I mean, it's not me too hard or not enough. So that's fine motor control. When that goes, we have we have a considerable amount of difficulty in movements in general. And so as we move on, here's the cortex. All of these things, guys, if I please no more, I'm going to clear the room. I hate to do this. I know it's near break, but it's got to stop. It's hard enough for me to hear myself. Cerebral cortex, executive suite of the brain, consciousness, awareness, all of these things that are there. Heavier than you would think for something that's barely a quarter of an inch thick. That is there. How do we know what they do? These are scans that have been enhanced with contrast. This contrast comes from radioactive labeling. It's called a functional MRI. So how do we know where sight is? Here. The occipital lobe. Hearing, temporal. Speaking, particularly this area, though I will not ask you about it, is called Broca's area. While this one is called Wernicke's, I don't want to have you sit there and remember a name, which you probably won't have to know again. These are centers that we really see a lot of problems with during stroke. Stroke is lack of oxygen or blood supply to the brain. Parts of it dies. And because of that, people with strokes, if they're motor, have difficulty speaking, enunciating words. They know the answer. They can't form the answer. It's got a fancy name. It's called expressive aphasia, APHASIA. And I mean, it's very frustrating. If you ever had to rehabilitate, and that's what a lot of you are going to do if you're going to nursing or physical therapy. I mean, stroke patients are everywhere. And it's so hard and frustrating because they know the answer. They just can't get it out. Well, write it down. Well, unfortunately, it's not always language. It's expressive. That means writing sometimes too, as well. This is a similar area for receiving. Some stroke patients, it affects there. They get what we call a receptive aphasia. Fancy name of the area is called Wernicke, named after somebody who identified it. And effectively, they can't understand what you're saying, but they can sure form the answer. I mean, you'll go and say, well, good morning, how are you? And they'll say, yes, I know today's Wednesday. Perfectly grammatically correct answer, stated and enunciated clearly, has nothing to do with the question. They're trying to play guess the question. And it's really, you see this, it's very interesting when you see these. I recall seeing stroke patients demonstrate a lot of these things over the years. And these, for many of you going into a clinical field, you see a ton of this. I mean, if you want, I only want to do pediatric. You don't start there. Most people start med surg. You see that. You see the people with the most common people are older with a consistent number of medical conditions. Eventually, you get where you want to go. Okay, but you don't start. You used to not do it. I've learned that has changed a little bit over the years. You know, from the old days of before there were university nursing schools. The nursing schools were attached to hospital, and they were very strict, to say the least. Another story entirely. Motor, sensory, and association areas. Covered that before. Incoming, outgoing signals, incoming signals, and the vast majority are association areas. Processing. Okay? And again, lateralization. If you're right-handed, you lift your right hand rather, left side of the brain. With the left hand, right side of the brain. The oddball about that is the cerebellum. That's the word ipsilateral, not contralateral. Ipsi means same, and so that's the cerebellum. My grabbing this involved more than me just moving my shoulder and arm. I had to coordinate a lot of muscles on this side. Hand, wrist, forearm, arm, shoulder, torso area. It remembers all of that. That's muscle memory. I don't have to worry when I say, oh, I want to get a drink. I just take a drink. I don't have to think about all those things. And again, I talked about these before. There's Broca's area. You don't have to know those kinds of things. I do want you to know the primary motor cortex is also known as the precentral gyrus here. And again, the name of these cells are interesting. Motor cells, these primary motor cells are called pyramidal cells. We'll see on Friday, when you look at that lecture and listen to it, there's two mounds on the anterior aspect of the medulla oblongata, the lowest, smallest part of the brainstem. They're called pyramids because they look like the base of a pyramid. We name these as pyramidal cells. They're the ones that do grab this. The ones that are similar in motor, that basically say how hard, how soft, how do I shaking doing this, a la Parkinson's disease. They're called extrapyramidal cells, outside of. Extra doesn't mean addition, it means extra to or extraneous, or outside of, really be a better way to describe it. Short, long, short story. You're going to hear a lot if you're going in any class, any course you have to learn about pharmacy, extrapyramidal symptoms. A lot of medicines give people the shakes, the tremors. Those are called extrapyramidal. That's a name that will help you. A lot of the names I'm giving you, when you hear one of those and I give you, and I indicate to you, this is relevant to pharmacology or whatever, write it down. Because now you'll be ahead of the game. You'll understand something. We gave it a name because of something anatomical. And we have, as you can see, we have constructed, and you see this is called a homunculus. It's a fancy name. All it means is we've mapped out the primary motor and the primary sensory gyri, and you can see how we interact with the world. How do we receive the world? We receive it for our mouths, our faces, our hands, our bodies, a lot of our feet, a lot of our palms, very little in the abdominal area, very little in the genital area, comparatively small. Where are we mostly? Where do we interact with it? Same basic deal. We speak, we use our upper extremity. Yeah, sometimes we use our lower extremity, but much less so. It's basically, think of how my interactions with you, I'm speaking, I'm gesturing, every so often I'll get up and write something, despite the bad handwriting. And you're all hearing me and listening to my voice inflection, all of those kinds of things, using those senses. That's how we're interacting with the world. And so these other planning areas, these association areas, do I want to drink or not? It's a lot faster than that. You're sort of debating, should I grab one now? Nah, I can wait another 5 seconds. And so, and again, a lot of these are things that we encode. So once we make a decision to do that, we do it. I let enough air into this about actively planning speech and voluntary. I mean, again, speech and writing, etc. So I'm buzzing through these, and if I'm going through that, I'm not going to be asking anatomy questions about that. Damage to this area paralyzes the muscles. The muscles become spastic. When a muscle like this is damaged, the nerve to a muscle like that is damaged, the nerve only spits out neurotransmitters that excite. So everything your brain is saying is fire, fire. Flexors overpower extensors, always. Flexors are prime movers. So they develop something called spastic hemiplegia, like this. They can have a drop foot, that's why we brace them at 90 degrees. We brace them at neutral like this so you can rehabilitate them. Once contractures start, if you don't get rid of them, the bones and the joints adapt to it, and it makes getting rid of them hard. Anything short of surgical intervention, which you typically want to avoid. Understand? I mean, that's why, I'm not asking you to repeat that as I stated, but the next time you have a stroke patient, if you have one, why do I have to wear this stupid brace on my foot? I can hardly walk. It's like at 90 degrees. I can't bend it. So when we can make it better, you can function better. So it won't be permanently have a drop foot and you drag your toe across the ground every time you take a step. That's why. There's a lot of that's why in what I'm trying to present to you. Muscle strength, all part of this as well. Even when they have that, okay, again, they give you the idea. It's funny because it's more about nerve damage than muscle damage is what they're saying there. Sensory, there's a zillion of them. Don't want to go through it. Ones that you should remember. I talked about them on Friday. Those proprioceptors, those little sensors that tell you so you can close your eyes and feel the floor and use your cerebellum and know how to keep your balance where you're walking and things like that. And again, they point to that same thing. And this is, then we take that information and we figure out what it means. I can close my eyes and reach out here. I know whether I'm on my phone, I'm on my AirPods, I'm on my drink, I'm on the keyboard, I'm on the mouse. You can do that. I can do that. But some people can't do And again, another one of those names to remember, I'm telling all the classes, Calcarin sulcus. I'm not going to ask you. Those are the funny things they put on tests like licensure exams. They love, because and traditionally, that's where people were told, oh, that's where you see. It's a little more complicated. Seeing these so many times on these tests, it just drives you crazy. I think it's more important to understand, but a lot of people associate learning a specific name to that. And so all of those types of things. Around the visual cortex, we pre-recognize. I'm looking out here, I'm already seeing, generally I'm going, oh, these are all faces I'm familiar with. I know a few names. As time goes on, typically by now I'm about a third of the names. I mean, most of the people I've interacted with because they came to the office or had a question afterwards, that type of thing. Not a whole lot. These are pretty straightforward. This is straightforward. Smell's a big player. When it says limbic system, that's how you remember things. Okay. Things that trigger emotions. When you do something great and you get a lot of compliments, you remember that. When you do something wrong, I'm fond of saying the most I learn is about mistakes. Trust me, as you get older, you get smarter. You get smarter by understanding how many mistakes you made when you were younger. You know what I'm saying? The older, the dumber I get, but the smarter I am. So you understand that. And I'm telling everybody that if you're particularly nursing, you can do 15 things right and one thing wrong. You will not get a simple pat on the back whatsoever from any of those 15 things. They will jump all over you for the wrong, because that's how you're going to remember. There's in clinical fields, there's minimal tolerance to wrong. Wrong hurts people. It really hurts people. Wrong can cost you your license. So, I mean, if you're going to be in this, if you're in it, you got to be in it to win it. Nothing like a good cliche. You got to be very serious about that. So, again, that's something to remember as well. We're going to see the limbic system, and I'll show you the outline. There's only a couple areas to remember. The hippocampus, about short-term memory. The amygdala, about rage. That's there. The importance of the sense of smells and triggering emotions. That's the olfactory bulb and the olfactory nerve. And these are maybe the most interesting and the hardest to, I dare say, to ask a question about. These multimodal association areas. This is our being able to give context, understand it, whether it's through emotions or thoughts or previous experiences, all this. I mean, it helps us decide on what to do. You know, if you're having an interaction with somebody that's going unfavorably, you were able to discern, should I strive to make my point or should I be conciliatory? Say, okay, sometimes you're better off avoiding the battle. That's where this comes from. It's the richness of our lives comes from filtering what we bring in with our emotions to it. The most important area to me is this. This is the prefrontal area, or prefrontal cortex. Not just because of intellect and cognition and recall, more about personality. All of those types of things. So when I look outside, if I try to say something funny and I don't get a response, it's pretty obvious. If I say something that maybe I shouldn't have said, and all of a sudden somebody's raising their eyebrows, I know I'm not immediately apologize. But sometimes the mouth gets engaged before the brain gets engaged completely. All of those kinds of things. If you have not seen this movie, you can find it on any one of these free platforms, Tubi TV, Pluto TV, bunch of commercials. Watch One Flew Over the Cuckoo's Nest from 1975. Best picture, best actor, best actress, best director. You get the idea. A picture about how we used to treat insanity, particularly criminal insanity, back in the 50s. Jack Nicholson got his first Academy Award. The late Louise Fletcher defined the image of a nurse who was mean to generations, Nurse Ratched. If you ever hear that reference, that's who she played. And this wonderful, kind lady played it. And a lot of times, the kindest people. Margaret Hamilton was a kindergarten teacher. That's the Wicked Witch. Come on, my pretty. kindergarten teacher. She was on Mr. Rogers, dressed as a witch to show there weren't any witches. She came out as not a witch and then took everything. She teaches kindergarten. When they told her she got the part. To understand. So what happened in that movie when they couldn't deal with Jack Nicholson's character, what they ended up doing, and it's worth seeing the movie. I'm not giving away the stroke because most people would be aware of this. They did what's called a prefrontal lobotomy. They took this out thinking that's what caused his mean, criminal, evil behavior. And basically you're left with a walking zombie, not the right term. Not somebody who's not, not Dawn of the Dead or, World War Z or any of these, modern interpretations. Basically somebody who was a non-person, who was just a functioning entity without any interaction at all. Lead them up, put them in the bathroom, go. Put them in front of the food, help them eat, etc. That's what they did to people. Yeah, the other thing they did was electroshock therapy. We only use that now for significant depression cases where medicines are not indicated. Understand, people who are depressed have a bad habit. If you give them a bunch of pills, they take that bunch of pills and they get a bottle of vodka and they combine the two because they want to end it all. They're depressed. This is real life stuff. Believe me, it's touched my family's life. Self-destructive behavior is everywhere. So I'm trying to make a point, again, limbic system, emotional center. So that's the prefrontal area. So that's not a test type of thing. That's these anterior association areas that are there. Any comments, so to speak, on what happens when these are affected? You may be interested in it. This is the idea of lateralization. Remember, everything is contralateral. Again, my right hand, my left side of my brain, the left hand, right side of the brain. Each of us has a dominant side. It's not 100%. You're looking at probably the closest 100% that there is. 90% of us are right-handed. When you're taking an exam, I'm always looking to see who's a lefty and who's a righty. Not for any reason, I just want to get numbers. And it's about 90 to 10. So, 90% left-sided, dominant, right-handed, 10% the other. To broad brush it, and that's why I said I'm this. Language, math, logic, that's me. What I'm not, visual spatial skills. My 5 and 6-year-old sons were beating me in Super Mario Brothers when they were 5 and 6. I get killed on the first level within a minute. Does it give you an idea like that? My artistic skills, non-existent. Okay. To me, most people are a blend. My wife is very much right-handed and very, very logical, intelligent person, lovely, but she's got a whole lot of artistic and creative ability. A lot of people do. I mean, it's funny what they can do. I mean, I don't see that in my children are all adopted, as you know. My son my sister's a lefty. She doesn't have a whole lot of this. Her intuition's pretty good. None of the other. She's much more language, math, and logic.
Can you be like, have better?
Yeah, absolutely. That's my sister would be an example of that. She's much more if there were anything, she wasn't very good at math. That was the whole thing. I mean, she's taking her MBA classes. She's calling me up for advice on how to do math problems and statistics. Sorry. She's smarter than I am. I'm teaching you guys. She was a corporate vice president. They're going to Europe. Last time we took a trip, we went to West Virginia on the Cheat River. It's actually pretty and cheaper. Cheat River, not cheap river. No fans of the Cheat River area in West Virginia? No. Oh, nice area. Oh. West Virginia's gorgeous. Pardon me?
What did you ask?
Me in Europe, never. One time. Played golf in Scotland. My sister, last time I was wishing her happy anniversary for her 55th? Yeah, something like that. I said, it was happy birthday last year for her 79th. Here's a happy birthday. I'm in Madrid. I said, oh, really? I said, well, I hope you're at a tapas bar. She text me back. I am at a tapas bar. Thanks a lot. I'm going to Permandy's for a sandwich. I'm there's so many good stories about that. I said, I go, wouldn't you like, for our anniversary, wouldn't you like to go out? There's this really great restaurant. She goes, how much do you think it would stand the two of us if we both went there and maybe had a drink? Oh, $50, $100. I will never let you spend that much money on two of us for dinner. Absolutely true. So, moving on. And there's a little bit more here to cover that. We're on B. This is the next part. We start to wake our way down. Now we get into white matter. 3 passageways, association, vertical, like this, back and forth, same side. Commissural. You did the corpus callosum. I'm sure you saw that in the sheep dissection. I would be confident that was pointed out. That is right and left. So even though I'm doing this with my right hand, my brain knows where my left hand is and my right hand is. So that's the way both sides communicate. And lastly, up and down, projection. So these are white matter. That's why we call them tracks. The name is not a K, but a T. Those are axons. Everything else, the gray matter doesn't have any axons in it. It's not myelinated. Okay. Association fibers, horizontal, connect same side. Commissural, 2 hemispheres, left and right. Projection, up and down. And for instance, like this one's famous radiating crown. This is the thalamus, which is editing and sorting sensory information from all over, sending it, okay, your vision, you're going there. Okay, your hearing, you're going temporal lobe. Well, you stepped on a tack. That's important. You're going up to general sensation. That's what it's doing. And it's assigning importance. Dope. Get that tack out of your foot. That, do you understand? I'm trying to make light of it, but that's a lot of that information we without almost subconsciously, and maybe that's a good definition for what the diencephalon does, is able to process that information and assort a value of importance to it, so we can respond to it. Like, how many times have you been sitting there? I'm hot. I may ought to turn the heat down, but I'm watching. I'm busy doing something else, and all of a sudden it becomes more important. It has a lower level of importance, so it really becomes uncomfortable. Now it's a higher level. So here they are, projection in this sort of darker color, up and down. You can see it crisscross. That's important. Fancy name when it crisscrosses here. You see pyramids is the name. That's in the medulla oblongata, and decussate is the fancy name for crossing over. Here, the red ones are same side. Those are association. The green, right and left connected. Commissural. Same here as the green. That's the corpus callosum. Fairly thick white matter. Here, you can see the red back and forth, processing all the information in the up and down in this darker color. When you talk about the basal nuclei, I call it, most of the terminology is called corpus striatum, striped body, because when you slice it, it looks like stripes. And that's where the term striatum, just like striated muscle, that are there. And again, this is very closely associated because it's exchanging information with the other areas of this, and particularly this one. When we get to the midbrain, which I'm not going to start today, I did it with the first group, but I barely got to it. That's where we produce neurotransmitters like dopamine and norepinephrine, the vast amount of norepinephrine. That's the dopamine, which only comes from the midbrain, that plays a role in Parkinson's. And that is it's got a fancy name. It's called the nigra striatal dopamine pathway. That's the one we associate with Parkinson's, where we have to use supplements of dopamine or dopamine-like substances to help. The other one, because another name for the midbrain is the mesencephalon, there's one called the mesolimbic. From here with dopamine, going to the limbic system, specifically to your pleasure center, That's the one that's all about addictive disease. That's what's going to addict you with one hit of smoking crack cocaine. That can addict you with one injection of heroin. There aren't a lot of things like that. Cigarettes a little bit different. Take a little more time. Alcohol more time. It's all about how heavy duty it is, how fast it gets into your body. This is what they look like. Not going into all of this that are there. These are the basic. So they play a role in cognition. Again, the slow stereotype movements. I mean, you can watch a person with these motor disorders walking, and you can see the difference between you and I walking. For instance, that's something I have a certain degree of expertise in. The fancy name we used to give to these, you don't have to know, is called chorea. That's another one you can impress whatever your major you're going in. It's not K-O-R-E-A like the countries, C-H-O-R-E-A. So chorea form were irregular movements. People with Huntington's look like it's almost like they're, an old marionette type of puppet, very herky-jerky. Same for Huntington's disease. And indeed, it used to be called Huntington's chorea. It's an odd disease. It's called autosomal dominant. It's in various clusters and area. Before they knew about it, and you don't have to know this, but before they knew about what caused diseases or genetic abnormalities and proteins and things like that. In the Middle Ages, they thought if somebody was ill, it was an act of God. They were in league with the devil. They were punishment for some sin. And they actually named these people with these herky-jerky movements, and they said they were doing St. Vitus's dance. So they actually named that. And I mean, somewhere, there's little things like that. So a lot of these things have names based historically because of the association with something evil or an act of God or a league with the devil and that type of stuff. That was really the foundations of a lot of our original culture. There are bleeding people to get rid of evil blood. It's one of their go-tos. Putting bird poo-poo on wounds. Not brilliant. The wound's clotted, by the way. That's why they used it. I mean, all the bacteria are in that poop, notwithstanding. So here, this is where they talk about the stripes and the basal nuclei. And then lastly today, the diencephalon, the thalamus, the largest part of it, relay center, all sensory information effectively, save maybe smell, goes directly through the thalamus and gets sent to the appropriate area with the appropriate amount of emphasis, importance, if you will. The hypothalamus, the link between the nervous and the endocrine system, that was attached to a little stalk called the infundibulum that points down from the hypothalamus, is your pituitary gland. And indeed, the back part of your pituitary gland is actually part of your brain. You have a neuropituitary gland and a glandular portion. And I mean, really, that's, when I say the link, that's where, when something happens to us and we respond rapidly, it's nervous. All that residual stuff, how angry you are, how fast our heart rate is, are we perspiring, all that type of stuff. Now you're dealing with endocrine action. That's there. And the epithalamus, which is the pineal gland, more about sleep-wake cycles. Here you can see it. We'll look at this more than once because we'll get to the midbrain, the pons, and the medulla, and the cerebellum, and there's that fourth ventricle. Here's the thalamus. Here's the hypothalamus. Here's the epithalamus or pineal gland. Here is the pituitary. So the thalamus, the largest of this, we have it up here.
Thank you.
You're welcome. Leave the $5. She wouldn't get anything. You think she was stressed? I love doing that. I could have done the old, what's it worth to you? I'm terrible. She would have smacked me. So that's the thalamus sorts, edits, relays. Mediate is a great word. It acts to mediate sensation, motor, it's your response in any direction. how much should I respond to this? Indeed, and if I'm responding, how it is, learning, memory. Cortical arousal means how awake or alert it should make you. Like, so, if I'm hearing that siren, I should be paying attention to that. Hopefully it's not coming for me. The hypothalamus, again, is all about the beg your pardon, the endocrine system. And there's that infundibulum, that stalk. All of these sensors, the blood-brain barrier is weak. So when it's detecting sugar or salt levels or other chemical levels or pH levels, all of those are here because that's where the blood-brain barrier, because normally your brain sensors can't act on this. Here, they can sense those irregularities and respond. So when we get to autonomic, that's where we really go into homeostasis 101. And again, it plays a role in emotions. I mean, sensing those things that it does, it's really part of the limbic system. But look what's here: pleasure, fear, biological rhythms, sex drives, other drives. There's so many things way past the scope of this course to discuss, as well as all these regulations and stuff like that. And then lastly, I mean, a lot of times, it's not always depressive issues that cause eating disorders or sleep disturbances or things like that. A lot of times they're really addressed to certain areas of the brain. So a lot of times we mistakenly just throw a big blanket and say, oh, put them on some kind of mild antidepressant or a larger antidepressant. This is some sort of, not always the case. And the pineal gland, again, we talked about the relevance of melatonin and sleep-wake cycles. And we're going to start here with the brainstem, and that what I will send to you, and do the other stuff. Thank you. We're good.